Good evening. Myself, Dr. Kavyasree. I'm first year DRMB rheumatology resident from Topiwala National Medical College, Mumbai. So my mentor is Nilesh Nolka, sir, and I will be presenting a case today. So a 64 years old female, she is a known case of type 2 diabetes and hypertension. She had a history of unstable angina in April 2024. For that, she underwent a percutaneous coronary intervention followed by stenting in the right coronary artery. The patient was started on dual antiplatelet therapy and rosuvastatin 40 mg. So in June 2024, she presented to us with complaints of difficulty in getting up from squatting position and crampy pain over the bilateral thigh for 7 days duration. So, and after that, she also started complaining of pain in the bilateral thighs and abdominal wall and associated with a periorbital puffing. So there was associated brownish to red colored urine and reduced the urine output. And she never had any history of weakness in the upper limb or tongue, no history of any sensory involvement, bladder or bowel involvement, no history of difficulty in swallowing of nasal regurgitation of the food, no history of any rashes over the face, tongue or limbs, no history of chest pain, dyspnea or palpitation. So on examination, patient was vitally stable. On general examination, there was no pallor, icterus, cyanosis, no rashes or ulcers or nodules. JVP appears to be normal, and there was bilateral pitting pedal edema was present. On CNS examination, her hip and thigh muscle appears to be weak with a power of 3 by 5. Her MMT-8 score was around 49, and the hip appears to be very tender to touch, and her hip movements were extremely painful. And rest of the CNS examination was within normal limits, and other system examination was within normal limits. So, on investigation, the hemoglobin count and the routine CBC was within normal limit, but SGOT and SGPT were appears to be raised, and the creatinine was 5.6 and BUN was around 55. And urine appears to be foggy and red, and urine albumin was absent, and urine output were around 1000 ml, and there was no RBCs or CARs in the urine. So we did a CPK a total of this patient, which was found to be elevated at the range of 15,000. LDH, serum LDH levels were also raised, and ESR and CRP were mildly raised. So we proceeded with an MRA of this patient, which was suggestive of shear hyperintensities in the bilateral thigh muscles. So at the end of this, we came to two differential diagnoses. First one is rhabdomyolysis with the history of exposure to statin. And second differential diagnosis was a possibility of IMNM. If, in some cases, IMNM can present with an acute kidney injury. So our two differential diagnoses were these two. So before going to the rest of the case, so statin can present with a varied manifestations, which could be non-immune mediated or non-immune mediated. So the non-immune mediated manifestations of statin-induced myopathy include myalgia and hypercyclemia, and toxic statin-induced myopathy and rhabdomyolysis. So myalgia and hypercyclemia are the most common manifestation, and this is the most common cause of discontinuation of statins, and it is characterized by a creatinine level up to 1,000 international unit per liter or up to the 5 times normal limit. So these things just a conservative management, just you can continue statin with monitoring of the creatinine kinase, and if the creatinine kinase levels is going to rise again, then you have to stop statin. And the second manifestation is toxic statin-induced myopathy, which is characterized by proximal muscle weakness and the CPK level of 1,000 to 10,000 times the upper limit of the normal. And symptoms usually will improve 2 weeks after the discontinuation of the statins. And the last one is rhabdomyolysis, which is characterized by muscle weakness, especially proximal muscle weakness, myoglobinuria, and tubular necrosis, and with a CPK total which is usually more than 100 times the upper limit of the normal. So symptoms will improve after statin discontinuation. So both toxic statin-induced myopathy and rhabdomyolysis usually will improve once the offending agent is discontinued. And if the symptoms are not getting improved, you should consider the possibility of a immune-mediated counterpart of the statin-induced myopathy, that is IMNM. So you should proceed with a biopsy, or you should send the HMG coenzyme reductase antibody testing. And in rhabdomyolysis, future use of statin is contraindicated. Toxic statin-induced myopathy also, the alternative statins can be used, or low dose statins can be used, or an alternative can be used. So coming to the immune-mediated counterpart, that is IMNM, it is associated with proximal muscle weakness and a creatinine keeping a level of around 10 to 1,000 times of the upper limit of the normal. And it, in 10% of cases, it is associated with a myoglobinuria and acute kidney injury. So even after withholding statin, there won't be any improvement in the muscle weakness or the biochemical parameters of muscle injury. So you have to proceed with a muscle biopsy, which will be suggestive of muscle necrosis with hardly any inflammation. Then anti-HMG coenzyme reductase antibodies will be positive. So these patients in general respond to immunosuppressive therapy, especially IVI. So our patient, we with the presence of proximal muscle weakness, myoglobinuria, and acute kidney injury, we consider the possibility of
1 minute
rhabdomyolysis
left.
as the first differential diagnosis. So we stop the statin. We manage the patient conservatively with IV fluids with monitoring of the renal parameters. Urine myoglobin levels were raised, and we did ANA and ANA blot and myoblot. Everything came out to be negative. And we monitored the patient. Her creatinine kinase levels gradually reduced, and creatinine levels also started falling, and her muscle functions also started improving. By that time, we also did the HMG coenzyme reductase receptor level also, which also came out to be negative. So the final diagnosis came out to be rhabdomyolysis in a patient with exposure to statin. Thank you.